respected seniors and dear friends. First of all, I'd like to thank members of the Anesthetist Society Facebook group for giving me inputs to prepare this presentation. This is about preoperative optimization. When we take a patient to the operation theater, if we can optimize the patient, we can reduce the morbidity, we can reduce the mortality, we can discharge the patient early, we can mobilize the patient early, and obviously we can reduce the incidence of complication. That's why preoperative optimization is very important. But if you ask yourself or your surgical colleague whether you send your patient to the physician for fitness, most of you will answer with yes. Many of us are still sending patients to physician for fitness. Do we really require to send patient to physician for getting fitness to give anesthesia? I'll say we don't require it. Anesthetist is the best person to give the fitness for anesthesia. We need to send the patient to physician to optimize the patient, not to get the fitness of the patient. But if I ask to surgical colleagues or anesthetist friend whether you go for PAC before all surgeries or not, I'm sure answer will be no. We, as a freelancer, we see the most of our patient inside our operation theater or in the recovery area just before the surgery. Even in big hospitals, sometimes to reduce the budget, patient is presented to anesthetist just before the surgery. Patient get admitted, patient comes to operation theater, and at that time only anesthetist sees the patient. So PAC is not done in most of the patients in most of the surgeries. This was the post I recently saw on the Learning General Surgery Facebook group, and they posted it for junior doctors. And this is about systems approach to preoperative evaluation. In this, the highlighted area is in the preoperative setting. The goal of cardiology evaluation is not to provide medical clearance, but rather to provide information regarding the patient's cardiac risk profile and management of option for the risk. So the role of physician or cardiologist is not to give fitness. It is to optimize the patient. It is to explain the risk, about cardiac risk or any other risk to the patient and how we can manage it. So who is the right person to optimize the surgical patient before surgery? Is it surgeon? Is it anesthetist? Or is it physician? We will try to find the answer during this presentation. This is one case scenario we are facing day to day in our practice. 55-year male patient posted for laparoscopic hernia. PAC is not done by anesthetist. No past history of medical illness. Surgeon has sent the patient to physician, and physician has written that patient is fit for surgery with due risk. And when you see the patient in the recovery area, you found that patient blood pressure is 190 by 110. It may be because of anxiety, or it may be some patient might be hypertensive and it is missed. We don't know the reason. So whether to go for surgery or we should optimize the patient. This is the dilemma. Case 2, similar patient, 70-year male patient with COPD for very small surgery, that is file surgery. Patient is IAD and on dual antiplatelets. Surgeon has seen the patients during OPD hours and forgot to take the history about antiplatelet medication. Patient is on OT table, no monitor attached, anesthetist arrives. Can we give spinal in this patient? No, because patient is on dual antiplatelets. Guidelines say we should not give spinal. Whether we should go for GA, patient is having COPD. We don't know whether it is optimized or not. Giving GA in COPD patient is obviously with higher risk of respiratory complication. So again, we are in dilemma. whether to go for surgery or postpone surgery. Case 3, diabetic obese patient for bariatric surgery. Patient is diabetic, and when HbA1c was checked, it was 11. Patient is in short neck with restricted neck movement, so obviously difficult airway, but anesthetist has not done PAC. No preparation for difficult intubation. Blood pressure is, blood sugar is obviously high. It is uncontrolled, whether to go for surgery or not. So these are the cases we are getting routinely in our practice, in our day-to-day practice. Why we are getting these patients? Because we are not doing PAC. We are avoiding PAC. Ideally, every patient should be seen by anesthetist before surgery. So if it is daycare surgery, surgeon must send the patient to anesthetist when patient comes for OPD consultation to surgeon. And if it is not daycare surgery, patient is admitted, then it is anesthetist duty to see the PAC. So question comes is, shall we proceed or to optimize? Why we need to optimize the patient? It is attempt to modify the physiological and psychological response to the major surgery. So if we optimize the patient before surgery, it will improve the or modify the physiological and psychological response to major surgery. It will reduce the complication and hospital stay. If we optimize the patient and then take for surgery, it will obviously reduce the complication rate and even hospital stay. Improvement in the cardiopulmonary function. If we can start some chest physiotherapy or some pranayama or some spirometry, then respiratory function can be better in the post-operative period. If we optimize blood pressure, then cardiac function will be better in the post-operative and perioperative period. Earlier resumption of the normal activity. If we take care of these things, patient can resume normal activity earlier. So there are two parts: pre-admission optimization and immediate preoperative optimization. So in pre-admission optimization, there are 6 legs: counseling of the family and the patient, nutritional support, cessation of smoking, cessation of alcohol intake, preoperative exercise, and medical optimization. So counseling of the patient and family, this is very important to reduce emotional and psychological stress. As we saw in the first patient had blood pressure of 190 and 110. Why? Because patient was worried about anesthesia, patient was worried about surgery. Patient had not met the anesthetist, so he had many questions regarding anesthesia, type of anesthesia, any complication along with anesthesia, whether I will get up after surgery or not. So there are many questions, and there is emotional and psychological stress. So if we meet the patient before surgery, this stress can be reduced. This stress is more common in female patients. So we must meet the patient before surgery. We should explain about type of anesthesia. We should explain about postoperative pain management. We should explain about any other question patient has. Then patient stress can be reduced. Preoperative nutrition. Again, this is very important. Poor nutrition is associated with detrimental outcome postoperatively, and it increases morbidity in the patients. So European Society defines the severe nutritional risk as weight loss more than 10 to 15% in 6 months, BMI less than 18.5 kg per meter square, or serum albumin less than 30 gram per liter. So we need to correct it. If we don't correct it, there are chances of postoperative complications like delayed wound healing, sometimes edema, severe albuminemia can lead to delayed healing. Even other complications are common in such patients. So we have to optimize the nutrition. Smoking cessation, this is very important. If we can convince the patient to stop smoking at least for 6 to 8 weeks, we can reduce post-operative morbidity by 50%. And this is the best time to convince the patient to quit smoking. Smoker have increased pulmonary and cardiovascular complication, increased or delayed healing of the wound and the bone. So if it is orthopedic surgery, there will be delayed bone healing also. So if you look at this article, they found that if cigarette smoking is stopped at least before 4 weeks, chances of pulmonary complication can be reduced. This is by Surgical Society of USA. They uh, are running a mission about quit smoking, and they think that if you can convince the patient before surgery to quit smoking, it is the best time to convince the patient, because the patient is in fear of surgery, and if patient quit the smoking at that time, there are all chances that a patient will quit smoking for lifetime. So they have prepared such informative brochures where they tell that chances of complications like heart attack, pneumonia, breathing problems is more with patient who is smoking. And this is the entire pamphlet. Even they provide some helpful numbers where they help them to quit the smoking. So this is how you can convince the patient to quit the smoking and reduce the complications. Same way alcohol cessation can be done, and patient might quit the alcohol, but sudden withdrawal of alcohol can lead to alcohol withdrawal problem also in the post-operative period. So you have to be careful. 73% increased chance of post-op infection is associated with chronic alcoholic patient. 80% increased chance of difficulty in breathing is seen in the alcoholic patient, and 29% increased chances of ICU admission are with chronic alcoholic patients. Pre-operative exercise, as I said, if it reduces the pulmonary complication, and this is we have observed, especially in bariatric surgery patient. If patients start pulmonary respiratory exercise or chest physiotherapy in the pre-operative period, at least 1 to 2 weeks before surgery, post-operative period is smoother as compared to patient who has not started any exercises. PO2 increases, it reduces post-operative pain scores also and anxiety also. So we were advising patient to do deep breathing exercises, pranayama, so that patient can understand it well. We were advising them spirometry, and it obviously reduces the chances of complications. Medical optimization is also important. We need to optimize hypertension, IRT, diabetes, and other metabolic syndrome also. So we have to take help of physician in this thing. We have to take help of physician to optimize hypertension, IRT, and glycemic control. PAC by anesthetist. This is very important. The anesthesia preoperative evaluation is the clinical foundation of framework of perioperative patient management and can potentially reduce operative morbidity and enhance patient outcome. So this is very important part. PAC is very important. We meet the patient, we can take history, we can examine the patient, we can see the investigation. If required, we can advise some investigation, and by that we can plan the anesthesia, we can plan the post-operative period, we can plan the pain management, we can explain the things to the patients. So PAC is very important. Fundamental purpose of PAC is to obtain pertinent information regarding the patient's current and past medical history and to formulate an assessment of the patient's intraoperative risk and requisite clinical optimization. So it helps to optimize the patient. This is a questionnaire. We can prepare our questionnaire. We have prepared in local language Gujarati, one questionnaire in local language that is in Gujarati. We Rajkot City branch of ISA are using it in all hospital, so that you get information directly from the patient. It will reduce the time of PAC. You will get vital informations like medical illnesses, allergies, whether patient is doing smoking or not, whether patient is able to take one flight of stairs or not, whether patient has done investigations or not. So all these things can be put in questionnaire, and you can easily get some vital information from patient only, so that you can reduce the time of PAC. Pre-operative investigation. This is a recently published guideline by Indian Society of Anesthesiologists, and this is for ASA 1 and 2 patients. So the most important part is many of this we advise battery of investigation in all patients, but it is not helpful. Many a times investigation may not influence the perioperative management and outcome. In such patient, we don't need to advise such investigation. So we should have some guideline with which investigation should be advised and which should not. So recommendation 1 is we should go for preoperative blood count testing in all patient, whether it is minor, intermediate or major surgery. Creatinine is not recommended in minor surgery. It is recommended in intermediate and major surgery. But if patient has any renal problems, preoperative only, then we should go for creatinine test even in minor surgery. Same way, sodium potassium estimation should be is not recommended in any surgery like minor, intermediate or major surgery. But if patient is going for, I will say, abdominal surgery or in the surgery where there are chances of electrolyte imbalances, then we should check the electrolytes. LFT, it is not recommended in minor or intermediate surgery, but it is must in the major surgery. But again, if patient is alcoholic or some pre-existing liver disease, then we should check it. VT and INR, we should check. It is not recommended in any of the surgery unless patient has chances of any coagulopathy or patient is on anticoagulant drugs. In non-diabetic patient, the recommendation is not to check blood sugar minor, intermediate and major surgery. But in our patient, we find many patients who are having higher blood sugar. We were not previously diagnosed diabetic because awareness is not that good especially in lower socioeconomic class patients. So it is better to go do sugar in all patients. In non-cardiac patient, we don't need ECG testing in all patient, but if patient is more than 45 years of age, we should go for ECG, even if it is minor or intermediate surgery. But I'll say ECG is a non-invasive investigation, and I prefer to do ECG even patient more than age of 20 years, because I have seen that we are getting many patients of IAD even at the age of 25 or 30. ECG is recommended in all major surgery. Same way, X-ray is not recommended for minor surgery, but it should be done in intermediate and major surgery, especially if patient is more than 50 years. Acceptance validity time for a previously performed normal blood count or any blood test should be 2 months, and acceptable validity time for a previously done ECG and X-ray should be 12 months. So if patient has done blood count or any blood investigation before 2 months, we can consider it, and if a clinical condition has not deteriorated, we can go with it. Same way for ECG and X-ray, it is 12 months. But these guidelines are for ASA1 and 2 patient, and best thing is the clinical judgment. So if you feel some investigation is required, you can always advise it. So if we revise it, complete blood count should be done in all type of surgery. RFT is not recommended in minor surgery. LFT is not recommended in minor and intermediate surgery. ECG should be done if patient's age is more than 45 in minor and intermediate surgery, but it should be done in all patients with major surgery. Same way, X-ray is recommended in age more than 50 years. If it is intermediate or major surgery. Electrolyte and other investigation should be done if it is recommended. Immediate preoperative preparation, it is just like ERAS protocol, that is enhanced recovery after surgery. Fasting and carbohydrate drink, bowel preparation, infection prophylaxis for thromboembolic events, and prevention of aspiration and nausea and vomiting. it is recommended to give 800 ml of bedtime and 400 ml of carbohydrate drink 2 hours before surgery. But in our Indian patient, I will say it is too much. So I will like to give 400 and 200 ml in place of 800 and 400 ml. It can be used in an NIDDM patient, non-insulin dependent diabetic patient, and it can be used cautiously in insulin dependent diabetic patient. Pre-operative fasting increases the metabolic stress, hyperglycemia, and insulin resistance. So if we give a fasting carbohydrate drink, it reduces the chances of metabolic stress, hyperglycemia, and insulin resistance. Mechanical bowel preparation is done by surgeon. It is troublesome, time consuming, and could be expensive. It requires admission day before surgery. It causes abdominal pain, bloating, and fatigue. It can cause fluid and electrolyte imbalance. Poor preparation may lead to liquid stool that will do intraoperative spillage, and it causes histological changes in the colorectal mucosa, which can be cause of bacterial infection. So it is avoided as far as possible. DVT prophylaxis, this is again important. It should be started one day before, once daily, low LMWH. It is given night before surgery and continues for entire length of patient stay in hospital, especially in the major elective surgeries. DVT is a devastating complication and it can cause mortality if it is not taken seriously. But when we are putting a fuel catheter, then we have to adjust the dose properly so that we can reduce the chances of epidural hematoma. DVT stocking should be applied in all major surgery, and it should be used intraoperatively as well as postoperatively till patient get mobilized. Antibiotic prophylaxis, this is important to reduce the wound infection. First antibiotic dose should be covering both aerobic and anaerobic organism, and it should be given just prior to the incising the skin. It should be repeated if procedure lasts more than 4 hours or if blood loss is more than 1500 ml. Pre-medication, again, it is not mandatory. Previously, we were giving all type of pre-medications like sedatives and analgesics and vagolytic drugs, but nowadays it is not recommended. Ideal agents to reduce the surgical stress response without sedation. So I will say patient's counseling is more important rather than giving sedative drugs. Beta blockers, if it is there, it should be continued. Same way alpha-2 agonist drug, it should be continued. We can give NSAID, PCM, dexamethasone to reduce the postoperative pain and for preemptive analgesia. But again, it is not a must. Routine use of anticholinergic as pre-medication is not recommended. Benzodiazepines are associated with prolonged extubation time and it may increase the risk of pulmonary aspiration. So nowadays it is not used, and even it causes postoperative delirium. Routine preoperative use of AT2 antagonists in patients who have no apparent increased risk of pulmonary aspiration is not recommended. So if patient has increased risk of pulmonary aspiration or patient with GRD, then only it should be given. So now I will ask again, who is the right person to optimize patient before surgery? Is it surgeon? Is it anesthetist? Or is it physician? I'll say it's a teamwork. We together as a team need to optimize the patient before surgery. If it is elective surgery, there is no hurry to do a surgery. We can optimize the patient, then we take the patient to the operation theater and can reduce the chances of complication. Anesthetist should be a leader in operation theater in the optimizing the patient before surgery. So we should take the lead to optimize the patient. And we are the perioperative physician, and we should take care of the patient before surgery, during surgery, in the postoperative period. Fitness for surgery and anesthesia must be by anesthetist and not by physician. We should take help of physician, but it is for optimization of the patient, optimization of the blood pressure, optimization of the blood glucose or any medical problem, but not for fitness or for surgery and anesthesia. This is for surgical colleagues that anesthetists must be paid for their preoperative visit. That will increase interest of the anesthetists to do preoperative anesthetic visits, especially for freelancing anesthetists. So this is message for our surgical colleagues that anesthetists must be paid just like a physician for their preoperative visit. Ultimate goal must be safe anesthesia, safe surgery, and safe patients. So this is all about how to optimize patient before surgery. Thank you. Thank you very much.